we're going to be talking about a condition that we see frequently in our clinic, which is evaluating and treating effects of a concussion or mild traumatic brain injury. We actually see this a lot in our practice and in the field of sports, and head injuries and concussions can occur, especially with contact sports, football, boxing, hockey. There may be a direct blow to the head or indirect blow to the head, and this results in alteration of mental function, dizziness, blurred vision, and other symptoms which need to be diagnosed. It's very important to make the distinction on the field because you have to make a decision whether you're going to allow that player to continue to play or if you're going to take them out. We also deal with concussions on a work-related basis. Individual painting a house up on a ladder accidentally slips and falls backwards. They strike their head and their neck, and they present with headaches, dizziness, and other symptoms. And of course, the same type of injury, the painting incidents can occur at home. You're at home painting your kitchen ceiling, and you accidentally fall and sustain injuries. Usually the work-related injury is going to be seen if it's very significant in an emergency room setting, same in a home setting. We'll frequently see individuals where we have to make the decision if you're the team physician on the football team, or they present to you, let's say, following a motor vehicle accident. So we've talked about symptoms of concussion. These frequently are headaches. There may or may not be loss of consciousness, but there's frequently dizziness and alteration of mental function and acuity. Oftentimes it's accompanied by headaches and other symptoms. We'll also discuss the fact that there's many times overlapping injuries. We frequently see motor vehicle accidents. And again, these are individuals that get rear-ended or side impact, and they present with symptoms of concussion, headaches, dizziness, blurred vision. And you have to make a determination whether they have actually a concussion or brain injury, or whether these are symptoms of what's called so-called Whiplash-Associated Disorders. And there's actually some overlap. People that get whiplash frequently also get headaches, dizziness, blurred vision, visual disturbance, hearing alteration, and these overlap with a concussion, and they need to be distinguished. So I wanted to get further information with my associate, Dr. Roya Moheimani, who has specialty training in dealing and assessing with traumatic brain injury and concussion, and I welcome her to our session.
Thank you so much. So just starting off with my background with traumatic brain injuries. So concussion is a type of traumatic brain injury. In my training, we learned everywhere from the severe to moderate traumatic brain injuries, and that's where you're getting brain bleeds from the impact. You're having loss of consciousness for more than 30 minutes. After the injury occurs, you're having this phenomenon called post-traumatic amnesia, where you actually forget the things leading up to the injury. And that's when you know you have a moderate or severe traumatic brain injury. Typically, what we see more in football-related injuries or occupational injuries or car accidents are mild traumatic brain injuries. So there isn't a significant loss of consciousness. There isn't a moderate to severe post-traumatic amnesia state. So the things that we're looking at are what are the signs and symptoms that would bring you to that diagnosis of a concussion. And sometimes it just takes a careful history by the provider, especially at a football game. That can be a little bit difficult because sometimes the athlete will want to go back to play. But it stems around a good, thorough, what I consider almost like a review of systems. So we're asking about, do you remember what happened? What do you remember? You actually have to observe the person. If you're on the field, you would look to see if the patient or the athlete was any signs of them being like limp and motionless. Obviously, if it's more severe injury, they can have seizures, they can convulse, there can be jerking. And then when they get up, there's sometimes incoordination. They're kind of like walking a little funky until they kind of shake it off. And then obviously if they're confused, so you ask them about orientation, what quarter is it? Where are we right now? And sometimes there's just that blank, vacant stare. And you look around to see if there's evidence of trauma on the athlete. that would probably be more consistent that it's going to be a pretty significant injury. And then when we're seeing, the typical day to day, I have a lot of patients that will come see me. Actually, time has passed from the injury, but they're recalling their symptoms that they have noticed since this injury happened. And that's often headaches. That's like probably one of the most common things that people will say they're having. Dizziness. And usually it's more intermittent, like they get up and they feel a little bit dizzy. And oftentimes they're having just some general fatigue, malaise. Sometimes they've got blurry vision, double vision, and it's usually more transient. Like it comes and goes and it fluctuates. And the very frustrating thing for some people is they get ringing in their ears, and that again comes and goes and can be very disturbing. And then it's a general sensitivity to light, to noises, and they can feel foggy, they can feel kind of irritable, and they can't really explain it. So depending on what the setting is, you kind of just collect a very thorough history, do a review of systems, and try to figure out where are we? Is this is this moderate, severe? Is it a mild concussion? You're trying to figure out, categorize. I first think of it as like what category of traumatic brain injury, and then within a concussion, what kind of concussion is it?
One thing I want to emphasize, especially as an orthopedic surgeon, is to make sure that when you're dealing with a head injury, you don't forget and very carefully assess the cervical spine. Head and neck injuries often go together, and I see when I evaluate individuals, it's often missed in clinics. They either focus on the head injury or neck injury and not the other. And the basic teaching is you've got to consider both head and neck injury at the same time. So on the football field, if there's alteration of consciousness, it's very important to take full spine precautions, guard the cervical spine, palpate the neck for tenderness or pain. And if there is any signs of that, to make sure you immediately immobilize it and then safely transport the football player or hockey player with full spine precautions. In a setting, in an urgent care or emergency room evaluation, again, if they present with headaches, very important to evaluate for a neck injury. Certainly, if there's loss of consciousness, it's mandatory to actually obtain X-ray and CT scan of the cervical spine. Because if the patient is not fully alert, they may have a cervical spine injury, which can easily be missed. So it's mandatory to obtain a CAT scan and CT scan. And if you're in urgent care and you do not have the facility, you should for sure transfer that individual to a local emergency room where they have the capabilities. So fundamentally, don't forget the neck and the head and examine both of them for injuries. But let's go to our football player who gets injured on the field. You're called to assess, how do you make a decision that it's for them to take them out or to play? It's going to be a quick judgment. What do you do quickly?
So, I mean, I think I see, first of all, if there's any evidence of a C-spine injury, I withhold them from playing. I think that, obviously the rules depend on your setting that you're evaluating. In the NFL, they may have slightly different criteria for return to play, but for the general public, when I'm assessing high school and all that, I'm definitely much more conservative. So if there's any evidence of that, they're out for the game. If they're giving me any signs of concussion, again, I would just withhold them from playing. I take a very conservative approach to this because oftentimes athletes will minimize their symptoms. So if there's any suspicion of all the things that I had mentioned, I would withhold them from play, at least for that particular event and for the whole day.
And when would you reassess them and make a decision for them that would be safe for them to return to training or to football?
So it's really interesting. The whole concept of return to play was actually based on the NFL schedule. It's a 7-day, they usually do a 7-day return to play. And the reason for that is they want athletes to be cleared to be playing the next week. So we follow the same thing. So for the first 24 to 48 hours, it's simple rest. We're avoiding stimulation. We instruct the athlete that they need to like take it easy. We withhold them. And if it's on a Friday night, luckily you got Saturday, Sunday to recover. So you're trying to minimize screen time. You don't want to be doing any training. You really want to like slowly ease them in. Now, if they're symptomatic, you're going to stop their progression even more. If you're symptom free, Then you start doing light aerobic exercise. So that's basically like walking, stationary bike, elliptical, all that. I would hold off on any resistance training in there. And then if you're symptom free the next day, then you can progress them to sport specific drills. So that can be like, running. You're not doing any kind of impact with that. And then you get even more complex and you're getting into the non-contact like training drills. So that could be like cutting, like catching a football, maybe shooting a puck or doing layups in basketball, um, lacrosse. And basically you're building up that muscle memory. Again, if there's no symptoms, then the next day you progress to basically the full contact practice. And ideally you would have at least some sort of like controlled environment for that, and then it would be full return to competition. But typically, it's a 7-day slow progression. This would be done in concert with the athletic trainer. Athletic trainers are mandated, at least for football, and they're very good at this protocol, and they have a good understanding. So you're going to be working with them to follow up with the athlete on this return to play protocol.
When do you make a decision to do imaging, either a CAT scan, MRI? Is one preferable over the other? And when should you seriously consider an imaging study?
So I don't, in the way I practice, I usually would not order a CT scan unless I had any reason to suspect a bleed. So if there is a progression of their symptoms, they're feeling unwell, nausea, vomiting, and it's getting worse, that's when you would consider a CT scan, and that's usually in the first 24 hours. Like you're thinking that there's some sort of like, uh, like fracture. So basically, you're looking for red flag symptoms because a CT is kind of an immediate study looking for bleed. So that's like they're losing consciousness for more than 1 minute. Their Glasgow coma score is really low. That's one of the head injury assessment scales. You're seeing vomiting. So like one episode of vomiting can happen, but if it's more than one, then you're starting to get really suspicious, and you want to let the family of the athlete know. You let the athlete know, like, if you're seeing these things, you need to go to the emergency room to get this done. Any kind of seizure, if the headache's getting worse, if there's anything on the face, any evidence of trauma, any neurological deficits, and actually older patients, let's say it was an older patients are actually very susceptible to bleeds, unfortunately, with traumatic brain injuries. And one of the reasons why is that a lot of them are on blood thinners. So that's going to make you even more suspect to order imaging. For athletes, they're younger. Usually, they're okay, but older patients, their brain volume actually shrinks as you get a little older, and so that actually puts more space for you to accumulate a slow bleed. So that's definitely something in the back of the mind. And then, obviously, if they're falling from something really high or the mechanism of the injury looks really bad, that's when you're going to be more aggressive. If we're moving more to like the football field, it kind of depends. That's why I think it's really important for sideline physicians to be watching the game, looking at the mechanism and all of those things. And if they're on blood thinners or they have a history of some sort of bleeding disorder, that would be even more suspicion to want to scan with a more invasive study, because a CT scan does have a significant amount of radiation, but it's very effective at detecting a bleed. And that's what the most scariest thing is with the acute phase of a mild traumatic brain injury. Now, for MRIs, that's usually what I end up ordering because I don't do as much sideline coverage. We're seeing more patients in clinic. And that's usually if we're getting persistent symptoms for more than, I'd say, like 1 to 2 weeks after whatever injury it is. MRI studies are advancing. There's a lot of new technology that looks at diffuse axonal injury, which is one of the ways that the pathophysiology behind concussion and why they're having the symptoms. And there's all these new there's no new imaging studies that allow you to kind of visualize that. Again, some of this is experimental. It's still in the research phase, but um, one of the reasons like I like to get an MRI is I also want to rule out that there's nothing else that's going on that could explain their symptoms. Sometimes it's actually they have a concussion and it's unmasking something else that could be there. So I think an MRI is a nice way to just make sure we're not missing anything else.
So let's say we go from the acute football injury to a clinic setting where a patient comes in, let's say after a car accident, they were rear-ended, they have neck pain, headaches, but they also tell you a history that they've had initially right after the accident, they had a vomiting episode. They still have a little bit of ringing in their ears. They have a little bit of change in the taste in their mouth, and they feel a little bit unbalanced. Now, These symptoms can occur both in what's called whiplash-associated disorder and similar symptoms in what's considered a concussion. Do they have both? Do they have whiplash injury and concussion? How do you distinguish between the two, and what are your first steps in evaluating and treating these symptoms?
I think that a whiplash injury, another word for it is a whiplash associated disorder, they typically overlap a lot with a traumatic brain injury. So there's similar mechanisms involved, and it's the whole idea of inertia. Isaac Newton, objects at rest stay at rest, objects in motions want to stay in motion. What is happening is that you have something going, and then all of a sudden it's stopping, and that's a lot of force. And the force has to go somewhere. So that's going to involve the head and the neck. And unfortunately, the neck is not very stabilized, and nor is the head. So imagine the brain floating in a nice little CSF, which is the fluid that kind of keeps and feeds it. It can go back and forth, and it can smack against the skull. And again, the neck also not well supported, and it has this large structure sitting on it. So we're pretty set up for in these kind of injuries to have both. They both can cause headaches, so that's what makes it confusing. You can have dizziness, you can have fatigue, you can have visual disturbances, you can have cognitive difficulty. Sleep is often disturbed, and there can be things with with mood changes, and both actually have very similar mechanisms. You don't need a direct blow to your head to have a concussion. That's a big common I think public misconception. Sometimes you can kind of use the location of the headache to try to localize. We often think of like concussion headaches as more like generalized, diffuse, sometimes frontal. And then the headaches that come from the neck, sometimes they're actually more at the base of the skull. So they're localized, they may be unilateral. So that kind of helps. And then the thing is with the cognitive symptoms that patients will complain about. You see that a lot more in a concussion than you would in a whiplash injury. So if they're like, "Hey, I was really able to memorize all these phone numbers. Now I can't. I had I had this system where I can like recall people's names really easily. Now I can't." I mean, those are signs that you're having a concussion because typically that isn't altered. The other thing that you look for is the neurological deficits. So if you're having a whiplash injury, you typically will not have the visual changes, the ringing in your ear, the balance issues as much. And so that's what's kind of tipping me off. And then, the whole idea that your symptoms are aggravated by sensory symptoms, that's kind of a neurologic phenomenon. So again, I'm thinking more of the neurologic central, the brain, getting all the sensory input. So sound, if you think about it, sound comes from here touching the brain. It's not really affiliated as much with the neck. Sometimes they'll explain that the sounds and light all bother them. So those are tip offs to me that they've had a concussion, just by the simple way that they explain what aggravates their symptoms. And then when it's a more whiplash related injury, they'll talk about their neck, like, "Oh, I wake up and I have this terrible headache," and that's because when we sleep, our neck isn't well supported or we don't have a great pillow. So you kind of want to piece together the little pieces of the puzzle to try to figure it out. And patients often have both. Just because you have one doesn't mean you don't have the other.
So, what would be, let's say you established that likely either they fell at home and hit their head or in a car accident, now they're having concussive symptoms. What steps do you take in diagnostic, and what kind of therapy or treatment do you usually advise your patients?
Yeah, so I think after you take a really thorough history, you do a good thorough physical exam to best treat your patients. You try to tailor it. So if they're having pain, I think treating pain, regardless if it's the pain from the neck or pain anywhere, slows people's progression from recovery. So if someone's having a concussion, but they also have back pain, or someone's having a concussion, they also have neck pain, treating those underlying mechanisms are super important for the recovery. So that might be prescribing physical therapy, chiropractic therapy, whatever modality that they're more comfortable with for treating the symptoms. If I think that they're having a concussion, we're going to try to eliminate stimuli that would aggravate or slow down the progression. So, as we were talking about the return to play, it's not dissimilar to any individual, whether it be an occupational hazard, car accident. If you have signs and symptoms of concussion, you want to minimize your screen time. You want to minimize excessive loud noises. Like I usually tell the patient, stay away from loud concerts, We're going to skip on any roller coasters, theme parks. And honestly, if they're having whiplash, it's not a good idea to go on there. So a lot of the things that you recommend end up overlapping. Aerobic exercise actually is a treatment for both. I recommend an aerobic program to all of my patients, low impact cardio. And that actually helps with recovering. So that can include 30 minutes, 5 times a week. That's usually what I tell patients to aim for. So that's kind of the scaffold, is trying to figure out what are the triggers and minimizing them. And sometimes we do basic, especially for concussion patients, but honestly, this would be good for any patient, is taking care of their basic needs, because what slows down recovery is high stress environments, not drinking enough water, not eating 3 meals a day, sleeping poorly. So just trying to do like housekeeping, general housekeeping, which ends up treating both conditions.
One thing that I've observed, that some of these patients, both car accidents and head injury patients, also present with what are called PTSD, post-traumatic stress disorder symptoms, a lot of anxiety, sleep difficulty, psychiatric symptoms. How do you distinguish between those, and how would you treat the PTSD symptoms that that oftentimes develop?
I do think that it's difficult to distinguish between all of these. I mean, there is certainly there's overlap between, PTSD symptoms and all of these. I think the nice thing is the treatment for all of these are kind of the same, in the sense that one is time. Time does help. As more time progresses, you will see improvement. Providing reassurance helps patients. And then again, the same treatment for PTSD, this is the same thing that helping with a mild traumatic brain injury, is incorporating exercise, minimizing stressful situations, stimuli. Sometimes we actually recommend, both for traumatic brain injury and for PTSD, cognitive neurotesting. And that's actually where you can really parse that out, that difference. It's like a 4-hour examination administered by a neuropsychologist, that if you really want to get to the nitty gritty and try to figure out what's going on, they're most equipped to do that. It actually takes a lot of time to parse out all of the symptoms. But sometimes we send them to those specialists. And actually, for our concussion patients, when they're having difficulty with memory, they can actually give memory strategies and different cognitive coping mechanisms, which are great. So the nice thing is that there's a lot of overlap in the treatment for all of the conditions, and a lot of it's just gentle housekeeping. So making sure that we're making for a good environment for the recovery, whether it be through exercise, diet, sleep, making sure that they're doing all the right things so that they can recover as quickly as they can. Granted, time heals all wounds is often what I'm telling patients in clinic.
A lot has been lately of repeat concussion, or the cumulative effect of repeat concussions. Again, this can occur at work if somebody hits their head a couple of times and injures their head, but certainly a football situation. So let's say you get a young football player, uh, aspires to play in the NFL, but they've had, unfortunately, a couple of concussions. And they want to return. What do you tell the parents? Should they return? Should they retire? What is the advice you would give?
This is a very controversial topic, and it's also a very personalized discussion. It really depends on their situation. I think at the end of the day, the data supports that as you have every concussion you have, there is, consequences. You're putting mileage, and once you have concussions, you're more prone to more concussions. You're also prone to longer concussion-like symptoms. And so now that we have all this information, that repeated trauma to the brain can also progress into CTE, or chronic traumatic encephalopathy, that can lead to memory loss. And the memory loss can set in a lot earlier. So that is you just educate the family. I mean, you educate the patient, but if it is someone under the age of 18, that's that's where the minor aspect comes in, the difficult aspect of medicine. I mean, even if they're over the 18, if they're a college athlete or they have NFL aspirations, that's where you have to basically give them as much information as you can. I often encourage patients to look up things on their own. I think it's great for people to do their own self education, and then you let them know the consequences. This is the worst case scenario, and this is the best case scenario. Um, I think it's a very difficult thing, and the NFL is actually struggling with this. There are high profile athletes who have had multiple concussions, and it's clear that they had a concussion and multiple of them, and what is going to be the long-term effect of letting them return and continuing this very hazardous activity. And it's also often people's livelihood too. So it's a very heated, difficult, controversial topic.
Thank you very much for your information. I hope this has been valuable to our readers, to our viewers, and I hope that they use this as medical information, but specifically, you should consult your own physician, or if we're in your area, you can consult us for further recommendations and a complete medical assessment. This is just medical information, but not in lieu of a medical assessment or evaluation.
Yeah, they always say this is not a substitute for seeing a physician. If you think you have signs and symptoms of a concussion, if you're concerned, please have a physician see you. This is more of an academic exercise, and we thought it would be fun to get online and kind of do some of the coaching that we do, but definitely have a physician evaluate you.